Hello, everyone, to the webinar today of the 24th March. And the topic today is biomechanics of the SI joint. We have a couple of staff that is talking about this very important topic. And this is today's program. And first thing is we start with introduction of myself. I'm Martin Blay, located in Switzerland, and I'm happy to be the chair of today's webinar. We will start with a talk from Daisuke Kurosawa, who is our president of the SIMEG, and then we go over to two engineers from Hokkaido, Mr. Toyohara, and then Richard Reggie from Los Angeles. Oh, from San Francisco. And then after that, we will hear talks from William Cross, from Dr. Clement Werner and Jeffrey Donner about using these surgical or these mechanic concepts in surgery of the SI joint. So this is our today's program. We see that we are across the world. We have different time zones, and over here it's in Europe, it's early afternoon, and we will go through this one after the other one. So we start with a little introduction. Here in Europe, this is where Dr. Werner and I am located, in Switzerland. Mm-hmm. And today, biomechanics of the SI joint. So the whole load of the body has to be transmitted over the SI joints. And this, in bipedal standing, it's some load, but in one pedal standing, it's a lot of more load, even in dynamics. And so how does this work? And I was taught that you can do this by the sacrum is just in the middle of the two big bones, and how can you get stabilization? And one thought could be form closure. This is very stable, but it has problems in dynamics. We have force closure, which is very difficult to reach stability. And we have a mixture of this, which is maybe a part of the SI joint. And then we have a lot of ligaments running around the SI joints that together with the muscles try to fix the joints in all positions and all needs. And this is maybe how it looks like from a mechanical standpoint. But this is very superficial, and these guys will now tell us how they think about SI joint concerning biomechanics. So we start with the first talk by Daisuke Kurosawa, and switch over to Japan. This is a long journey. Stopped. So Daisuke, please start. Sorry.
Okay, I will start. Thank you for joining us tonight. I'd like to talk about new SIG anatomy and biomechanics to understand the pathology occurring in severe cases. Oh, just a moment. Slide note. Okay. The first question is what is the sacroiliac joint for? Actually, these SIGs have played a very important role in human evolution. In order to walk on two legs, the area of the SIG in the pelvis was expanded. Now, so I'd like to promote this. Okay, so I will talk about three SIG functions. The load transfer and shock absorber functions are well known. In this presentation, I will also introduce the third function. As you all know, the SIG is located in the pelvis at the base of the spine. the SIJs are responsible for load transfer between the upper and lower body. The SIJ consists of the anterior articular region and the posterior ligamentous region. Within these two regions, the SIJ works. I'm sorry. I think the Zoom is very heavy now, so I cannot proceed.
Do you have the echo problem?
Do you have echo problem? Yeah, I don't know why. I don't know why.
I think the others need to turn off their audio. Everybody should be mute, maybe, except Daisuke.
Okay, please mute everyone.
I think the meeting host can mute people.
Host can mute. Okay. Just a moment. Just a moment. どうすればいいのかな。mute. Okay. I muted everyone except for me, except me. So I will talk again. Okay, I've enjoyed teaching and practicing SIJ anatomy with medical students for past 6 years. In our local area, today's young medical students know a lot about the sacroiliac joint before they become doctors. An orthopedic professor was surprised when a medical student mentioned sacroiliac joint dysfunction in the diagnosis of lumbar buttock pain in clinical practice. My strategy was successful. Let's observe the left SIJ articular surface in actual dissection. As shown here, the sacrum and the ilium are separated. This is the iliac side, and this is the sacrum side. You can see the articular region. Observing the iliac side of the joint, we see a triangular or trapezoidal shaped prominence here. This is all iliac articular area, and within that, the provenance is here. Again, on the other hand, the sacral side has a similarly shaped depression that is one size larger than the iliac side. The trajectory of the movement of the SIJ articular surfaces was unknown. This is a piece of sacrum, including left side of the joint surface. I found that the sacrum slides well forward and backward and rotated. However, when I tried to move it vertically, it stopped immediately. Again, slide forward and backward and rotate, but vertically it stopped. In other words, the joint slides well in the horizontal direction due to its trapezoidal shape. It also has a relatively high degree of rotation range. However, in the vertical direction, the bottom edge of the trapezoid touches the surface, restricting its movement. There is an interosseous ligamentous region here. Professor Niels Hammer mentioned that there is a fat in this area, and fat tissue itself also contributes to shock absorption. And I agree with his opinion. The interosseous ligament region also appears to define joint motion as well as articular region. SIJ-related ligaments regulate the movement of the joint. These include the anterior and posterior sacroiliac ligaments, which are part of the joint component, as well as the long posterior sacroiliac ligament, the sacrotibialis ligament, and the sacrospinous ligament and iliolumbar ligament. Of these, Fleming reported that the sacrotibialis ligament, or STL, controls the sacrum nutation, while the long posterior sacroiliac ligament, or LPSL, controls counter nutation. These are well-known SIJ biomechanics. Regarding the histology, we found fibrocartilage structures around the SIJ-related ligament bone attachment site. Fibrocartilaginous structures increase ligament strength. The purple area are the sites that correspond to stress. Now we are looking at the PSRS, LPSL, and STL on the right side. As you can see, the surrounding ligaments are working hard to control the slight movement of the joint, like this. As Mr. Tuhara will talk about in detail in the next presentation, our research confirms that in addition to load transfer function, the SIJ also works as a shock absorber in bipedal walking. In summary, the SIJ has a trajectory of movement defined by joint surface shape, and the surrounding ligaments regulate movement and absorb shock. The SIJ seems to have a structure and function adapted to upright bipedal walking. Furthermore, the left and right SIJ movements are linked while walking. When one side is nutation, the other side is in counter nutation. Sacral rotation axis should be oblique. The SIJ moves with maximum range of motion during bipedal locomotion. Gross anatomy shows that the SIJ is nearly flat joint, so the range of motion increases when the joint surfaces are slightly separated. Conversely, a tight fit limits the range of motion. When force closure decreases, joint surface become apart and joint movement trajectory cannot be maintained. This will increase risk of joint derangement. In patients with chronic SIJ dysfunction, deviated movement from the normal trajectory continues for a long time. Then an abnormal groove will form on the articular surface. Continued mechanical stimulation causes increased bone metabolism in the subchondral bone, and bone SPECT-CT scan shows accumulation there. Dr. Koga in Kyushu Sacroiliac Joint Center in Japan has published these important findings in patients with severe SIJ dysfunction. Now let me talk about the third function of SIJ that we discovered using the Android model. We found an eccentric engineer, Mr. Sanaka, who had made bipedal walking mechanical robot with sacroiliac joint parts in 2012. He started developing mechanical robot in 1993, and it worked in 2000. After repeated trial runs, it took 7 years to make it work. I was very surprised that he made robotic sacroiliac joint parts for this purpose. I was happy because I knew that human could not work without the structure of the SIJ. But he said a human could work without the SIJ structures. I was a little bit disappointed. He said human could not work without spinal movement. But later, I understood his theory. He has been developing bipedal Android for more than 30 years without anyone asking, I don't know where the passion for creating them comes from. I've spent almost 10-year period trying to understand the principle of his theory. So you may not understand it immediately either, but I'd like to share with you the progress we have made in getting closer to the truth of the SIJ biomechanics. He found that bipedal walking principle from an Android model. Inertial force produced by spinal movement in source major muscle contraction is essential for bipedal walking. This theory was accepted by scientific journal Gait and Posture in 2022. I was very surprised because the reviewer in this journal accepted his theory immediately. So as you can see, when there is a source major muscle contraction, the legs moves forward like this, but without it, no matter how many other muscle contract, the legs will not move forward. The source major muscle contraction is very important. One day, Mr. Sanaka mentioned to me that the upper anterior and lower posterior part may have different role based on the shape of the articular surface. The upper anterior region may have a role for opening or closing the innominate bone, and the lower posterior part may have a role for lateral rotation or flexion of the innominate bone. Using an Android model, we investigated role transfer site of SIJ during bipedal walking. Mr. Sanaka constructed a system by attaching an aluminum plate to the anterior side and the posterior side of the articular model. When it made contact, light would turn on. So depending on the gait phase, the light was turned on differently. From initial contact to mid-stance, the anterior side was contacted and upper light was eliminated. Then during terminal stance, the posterior side was contacted and the lower light was turned on. In summary, we found that different SIJ surfaces were used depend on the gait phase. From initial contact to mid-stance, anterior side is contacted, and on the other hand, terminal stance, posterior side is contacted. The third function of the SIJ is force element distributor for human bipedal walking. The SIJs distribute the inertial forces generated by the spine for walking to the required force element according to the gait phase. From initial contact to mid-stance, the anterior side is contacted and distributes the force of rotation in the axial plane. During the terminal stance, the posterior side is contacted and distributes the force of rotation in the coronal plane. Now we know the force element distribution function of the SIJ. The SIJ is essential for highly efficient human bipedal walking. I'm not sure whether these examples are appropriate or not, but my image of the third SIJ function are these. With this discovery, I felt a kind of growing pride in studying this wonderful, mysterious sacroiliac joint. There are two studies regarding stress on the SIJ in athletes. The findings of bone marrow edema are often seen on the anterior superior sacral side and posterior inferior iliac side, suggesting that the location of the SIJ surface where the load is applied differs depending on the type of sports. Professor Kaneoka, who spoke at our last webinar, also reported this kind of findings. These are bone spectral CT findings from our recent cases. This 33-year-old woman with left SIJ dysfunction shows accumulation in middle, and lower area of the SIJ. Just a moment. We have 3 participants, new participants now. Okay. So on the other hand, this 24-year-old woman with left SIJ dysfunction showed only in lower area accumulation. Okay, this 32-year-old woman shows accumulation in all area of the SIJ. If the site of accumulation on bone spectral CT are different, the pathology that occurs may also be different. The Android model provided us with good inspiration for clinical practice. By the way, Japanese have kept a fascination with human and humanoid robots. There are many animation stories with humanoid robots, and Honda and Sony, these Japanese companies have developed humanoid robots, but they are not so useful. I don't know what the industry wants to do with these bipedal walking robots. Robots as pet animals named Aibo or waiter replacements seems to be more useful than humanoid robots. We conducted the 3-dimensional motion analysis of an Android model. Of course, for the first time in the world, we were able to confirm the similarity to human gait in the trajectory of the center of pressure of the plantar foot. Humanoid robots developed so far do not follow human walking principles at all. However, Sanaka's Android model is able to represent some of the principles of human gait. Such a robot has not existed in the world until now. With Sanaka's Android model, we can mimic the post-operative condition and study the effect on gait in near future. In our previous study, we knew that walking stride reduced after SIJ fusion surgery. This picture shows that walking stride of the right lower extremity, dotted side, this is the fixed side, is reduced compared to the healthy side. I wanted to perform SIJ fusion surgery on the Android model made by Mr. Sanaka and observe its changes. Mr. Sanaka created the model of left anterior SIJ arthrodesis. As you can see, difficulty moving the left lower extremity forward. This is a fixed side. It's just the same as the clinical case. Our ultimate goal is studying the anatomy and biomechanics of the SIJ is to reach knowledge that will define the boundary between the conditions that can be treated conservatively and those that require SIJ fusion surgery in patients with severe SIJ dysfunction. I respect Dr. Ben Strussen because he has studied SIJ biomechanics well so far. Instability or hypermobility could not be measured in patients with SIJ dysfunction in his previous research. He calls the SIJ state that lost an ability of bear weight is SIJ inability, and he says that is a true indication for surgery. This is a patient who was able to return to work after right SIJ surgery. Before the surgery, she could not support her weight with her right lower extremity. This means the SIJ inability. Post-operative results are excellent in these cases. There are my current research questions. Is the failure of the basal aspect of the SIJ the cause of the load transfer disorder? Is this a pathology that leads to SIJ fusion? What is the relationship to the pubic symphysis, particularly in women patients? Thank you very much for your kind attention, and thank you very much my mentor, Dr. Murakami. He has always supported and guided and encouraged my SIJ researches with tremendous passion for the past 15 years. Thank you very much.